Beautiful. Thank you so much, team. And so we are recording right now, and I have the privilege of introducing our speaker for the night, Dr. Lucy H. Young. Dr. Lucy H. Young, MD, PhD, FACS, is an associate professor of ophthalmology and the director of the Lancaster course in ophthalmology at Mass Eye and Ear, Harvard Medical School. She received her MD degree from the University of Wisconsin-Madison, her MA and PhD in biology from Harvard Medical School, after which she completed her ophthalmology residency and fellowship in vitreoretinal surgery from the Massachusetts Eye and Ear Infirmary. Dr. Young's extensive research contributions include basic science, imaging, and treatment advances for choroidal melanoma, studies to improve diagnostic and therapeutic techniques for infectious retinitis, and serving as site principal investigator or co-investigator in numerous multi-center clinical trials. Her contributions were honored with the establishment of the Samuel and Nancy Jo Altschuler Ophthalmology Surgical Training Laboratory at Mass Eye and Ear. Since 2002, Dr. Young has served as the director for the Lancaster course in ophthalmology, the largest and oldest ophthalmic education course in the world, helping to raise funds from her generous patients to enroll physicians from underserved countries for free. In the past few years, Dr. Young has focused her efforts on teaching. She has been recognized with numerous teaching awards and honors, most recently as the 2023 recipient of the Simmons Lessell Excellence in Education Award. Dr. Young, thank you so much for joining us.
Well, thank you so much. Let me share. Hold on, just want to. All right. So I want to thank Nathan's the one who has been communicating with me, and he and all his colleagues who have put this curriculum together. I know some of the speakers you have had, and I feel humble to be considered in the same club with them. So I know I was given 30 to 40 minutes, so I'm going to be really quick, okay? Because there are lots of cases I want to share with you so that by the time you're done with this lecture, you too will also want to be a retina specialist, nothing else. So before I share with you the different cases, I'd like to just tell you a little bit about me, and so that you have a better understanding of the driving force behind me. What has driven me this far. So, all right, let's just start off. 1949, my parents left China. They fled China. That was when the communists took over. They fled to Taiwan. They were teenagers, and eventually they found each other, married, and had 4 of us. In 1965, they decided that it was time for them to leave Taiwan because they had no idea whether their parents were alive or not. There was no way of communicating with China, because if you're caught writing a letter or doing anything, even if you try to do it through Hong Kong, you'll be labeled as communist, and then that would be kind of the end of you. So my parents took the 4 of us. We all went to Brazil. We immigrated there, and very poor, even though my dad was an engineer, my mom a nurse. Because they didn't speak Portuguese, they took on all kinds of menial jobs to keep us housed and fed. And so, but no matter how hard they worked, they never lost track of our education. And then as soon as I finished high school, I went to Madison, Wisconsin. And so I am immigrant ×2. So you can already see what is the force that drives me. And watching my parents work so hard, you just want to be the best possible student. So Madison, Wisconsin, I spent 6.5 years, 3 years in undergrad, and then 3.5 in medical school. As soon as I started doing clinical rotations as a medical student, I knew I wanted to be a surgeon. I just loved being in the operating room. I loved just everything about surgery. And I really couldn't stand the 10-page workups of all those internal medicine rotations and long-winded morning rounds, every morning. So for me, I just tolerated my internal medicine rotations and just loved general surgery. But then I noticed that I really did not like to stand for hours and hours and hours at the operating table. My legs just really did not like that, just felt like they were going to burst. So I knew that I really needed to find a surgical subspecialty. And so I signed up for every possible surgical subspecialty that my third year allowed. And hoping that I could find a surgical subspecialty that had shorter, the cases were shorter, and that I would do them sitting. And another thing that it was a must is that I wanted something that was nice and clean with no yucky drainages and all that. So that I quickly narrowed down that ophthalmology was what I wanted. And this was like early 70s, mid 70s. And so at that time, when I was thinking about applying, ophthalmology was the number one, was the hardest residency to get matched. And so I, talked to various people, and I knew that I really needed some kind of publication. So I approached a very nice neuro-ophthalmology professor and asked him whether I could do 2 months rotation with him. And he said yes. And then right away, then I said, oh, by the way, I also need a publishable project. And of course, then he chuckled and said, this is all, everybody comes to me for that. And he warned me, he said, I've had many medical students, and I have yet had a medical student complete a project in 2 months. And so I took on the challenge. I surprised him, and I was able to finish that project in 2 months. And so now I felt ready. I felt like ready to apply for ophthalmology. I had something to brag. And this is when a very dear undergrad professor, a biology professor who had known me, followed my career and my training. And so he knew I was a younger medical student. And so he said, I really think you should spend a couple years broadening your horizon and do some basic science research. I kind of didn't want to do that because I felt like I knew I still had like a good 6 years, internship, residency, and probably a couple years of fellowship. I kind of argued with him back and forth, and before I knew, he connected me with this a visual scientist professor at Harvard. This is somebody when he was a postdoctoral fellow at Harvard, he had met this very nice professor who had just returned from Hopkins and was at Harvard Biolabs and was very well liked by his students. So he remembered that. So next thing, I communicated with Professor Dowling, and before you know it, the day I finished my medical school, I was at the Harvard Biolabs starting all over again as a graduate student in John Dowling's lab. Now, within a couple months, I learned just chatting with various with graduate students and getting to know them, and learn that some of them were on their 6th year, 7th year, 8th year graduate school. And that just petrified the hell out of me, because I thought, no way, if this happens to me, I'm going to be 40 years old, by the time I finish, I become an ophthalmologist. So I worked my butt off. The first 2 years, no data. I was about to quit, but my wonderful professor Dowling, he had a lot of faith in me for whatever reason. He saw that I was working very hard, and he kept pushing me and encouraging me. And then year 3, I got data and was able to graduate. And I had no doubt, without my PhD with Professor Dowling, I would have never got into the residency program at Mass Eye, where I have then continued with my fellowship and then never left. And you can see this was my class. 5 out of the 8 residents had MD, PhD. And you can see I was the lonely woman in my class. And so I have no doubt that without my 3 years with John Dowling, I would have never competed for such a good training program at Mass Eye and Ear. Okay, now I told you how I got into ophthalmology. Now why retina, right? So as a junior resident, we spent a lot of time in the emergency room. Mass Eye and Ear is the trauma center of New England. And so we just see trauma after trauma. And so you see ruptured globes, which is the layer underneath the retina. So this is a patient following blunt trauma, bruised retina, this whitish retina we call Berlin edema or commercial. I'm just going to go through all these great cases that I saw as a junior resident that sort of lured me into retina. This is a 17-year-old young man who had a fist injury and vision was down to 2100. You can see hemorrhage around the optic nerve, bruised retina, whitish retina, and a macular hole. Retina tears, giant tears. This is a dialysis that we saw from trauma, and retina detachment. There's a tear hiding, I think here, that it's not well captured. So lots of great cases. And then here is a hockey stick injury with macular hemorrhage. This is a patient with poor vision comes into the emergency room. Obviously, you know this patient did not develop loss of vision overnight. Often we see patients who love to show up in emergency room. You know, they don't have established care, so they use our emergency room for all sorts of situations. So this is a patient with poor vision, 2100 in the right eye, 2400 in the left, a lot of exudation, scatter hemorrhages in both eyes. And so this patient had a quick blood test and showed that clearly that was a diabetic patient with no known history of diabetes, but also with hyperlipidemia. And many of you, I know, are first and second year medical students, so you probably have already read about white center hemorrhages. This is a very unfortunate 23-year-old man with fever and weight loss, and all this little white center hemorrhages, and workup revealed that he had leukemia. This is another patient that came to the emergency room with gradual loss of vision in both eyes, 50-year-old man. And when we see picture like this with lots of cotton wool spots scattered around and in the posterior pole in both eyes, the differential is long. You have to think about compressive chest injuries, long bone fracture, pancreatitis, malignant hypertension. So the differential is long, and this patient turned out to be an alcoholic and had acute pancreatitis. And then once he sorted out his life and started taking our recommendations, you can see the cotton wool spots went away. Another very interesting case that I was seeing in the emergency room, an 8-year-old boy with floaters. And you can see this floaters happen to be vitreous hemorrhage. And when you look a little bit further out, you see that there's something fleshy, like a sea fan. And definitely this is a neovascularization. And angiograms confirmed that this little fan-looking thing turns out to be retinal neovascularization. And plus angiogram shows that there's a lot of ischemia. There's no perfusion here, no fluorescein going all the way to the periphery. So this is a very ischemic peripheral retina and no history of prematurity. So this is not retinopathy of prematurity. This is not sickle cell because the patient has no hemoglobin abnormality. And then turn out to be, again, it's a long differential. This kid had familial exudative vitreoretinopathy. You don't have to remember this, but just all these great cases that we see in the emergency room. This is another very interesting case. Patient has decreased vision in the right eye. And note how the cupping is different. The cup in the right eye is much larger. So now you think about glaucoma. Glaucoma in one eye, or at least is worse in the right eye. And plus, if you look more carefully, the fundus color is different. The right eye is kind of almost orangish, reddish orange, and then the left eye is more yellowish. So there's definitely a difference in color and severe cupping the right eye. And here I am showing this person has angioma on the face. So this patient has Sturge-Weber hemangioma, and the back of the eye underneath the retina has diffuse choroidal hemangioma. And that's why you see that color difference. And then patients with this condition often will have glaucoma in the eye on the side where they have cutaneous hemangioma. Now, this is a patient with very ischemic retina here in the infratemporal quadrant in the right eye, and retinal ischemia in the left eye, infratemporally, and then another area here. And so it's a 36-year-old man and is complaining about black spots in both eyes. So there's definitely branch retinal artery occlusion in each eye. Now, what is interesting is the additional history. The patient also has memory and hearing loss. So young patients, if they have a PFO or a valve disease, they will show up with embolic branch retinal artery occlusion more likely than like in one eye. This person has in both eyes, and then you can see has another area here hiding. And so this is like multiple branch retinal artery occlusions. And there's something odd about this patient. So it's not like your typical embolic cases. And then fluorescein angiograms show that this patient has vasculitis. A straightforward branch retinal artery occlusion, there's no vasculitis, just a blockage of an arterial. So this person has Suzak syndrome, which is a condition that affects the retina, the cochlea, and the brain, affects the arteries, a patient has vasculitis in all these three areas. And so that's why they often will have memory loss, sometimes personality changes. And we often, as ophthalmology, are the first to make the diagnosis of Suzak. Another very sad case, a 10-year-old boy with blurred vision and double vision from a left sixth nerve palsy. You can see massive disc edema. There's you cannot see the margin of the optic nerve in both eyes. And a lot of exudation throughout the macula. The macula in both eyes are very thickened. 20/60 in the right eye, 20/30, still working pretty well, this macula. And when you see this kind of finding, first thing you have to think of is high blood pressure. And the kid turned out to have pheochromocytoma. Another very interesting case, 50-year-old man with recent loss of vision in the right eye. You can see the veins are markedly engorged and dilated and tortuous. The nerve is very edematous and hyperemic. The patient also reported hearing swishing sounds in his head. And then here, external photo shows some kind of corkscrew vessels on the superficially. And so this person turned out after workup to have a CC fistula, a carotid cavernous sinus fistula, and underwent embolization. And this is 3 years later. You can see how the vessels, the veins are much less engorged and tortuous, and the nerve is back to almost normal. So these were the cases that I would see as a junior resident. And the last one that really made me just like totally convinced that I wanted to go into retina. Again, I saw this as a junior resident. And this is a woman that was applying mascara to her other eye and suddenly noticed that she couldn't see out of this left eye. So she came with sudden loss of vision, but obviously, you know, this was a pseudo-acute. She just noticed it. But with all this exudation, you know, this has taken months to occur, to develop. So this is a pseudo loss of vision. and the patient has a lot of macular exudation. Now, what do? You look a little bit further down, and you see this fleshy lesion inferiorly. And then now you can see that there's what we call feeder vessel. There's a very, very fat vessel that's going to this fleshy lesion. And fluorescein angiogram confirmed that this was a retinal angioma. And so guess what this patient had? Very sad case. She was worked up. She had cerebellar involvement. She had kidney involvement. And so she has von Hippel-Lindau disease or syndrome. And they have angioma in various parts of the body. And it's just very poor prognosis. So if I haven't convinced you by now why one would choose to go into retina, then I don't know. So this is what I loved about the retina subspecialty. And then surgically, also amazing cases that one sees. We do the retina surgeons are in charge of fishing out whatever gets dropped to the back. So the cataract surgeon will do beautiful cataract surgeries. They can do repair corneal wounds. But if an injury occurs to the deeper part of the eye, or the lens drops to the back, or after a complicated cataract surgery, some of the lens fragments drop to the back, again, they call the retina surgeon to retrieve them. So this is an intraocular lens that got dropped to the back, and then we retina surgeons retrieve them, bring to the front. Another thing that we are often called to retrieve out of the eye is intraocular foreign body. Anytime you hammer on a hard surface, then you run into risk of something chipping off, and then at high speed will land into the back of the eye. And so this is a subretinal intraocular foreign body that that needs to be removed, and it's done by a vitreoretina surgeon. Here, this is a patient who did not come right away because he didn't even know he had an intraocular foreign body. Shows up 6 months later with asymmetric pupil size. So it's called anisocoria. And also the iris color change. You see, he's a blue-eyed person. Now his right eye is no longer blue. So he has sluggish, dilated pupil and with a different color, and turn out that he had an intraocular foreign body embedded in the peripheral retina. Visual acuity is still 20/20. So, and then retina detachments, with tons of retina detachments that require us retina surgeons to fix it. So I then decided that I wanted to go into retina. So it's just, I love the medical conditions, and then the surgical procedures is just sort of, and then combine the fact that my PhD work was with retina. So it made all the sense for me to choose retina as the subspecialty. So how do you fix a retina detachment? There are different ways. For young people, we try to do externally. We try to do it without violating the eye, because this way then we preserve the lens. So this could be a 20-year-old, and I can guarantee you 40 years later, this patient still has attached retina and clear lens and excellent visual acuity. When you do from the inside, which is called vitrectomy, and endodrainage, that method often will cause a cataract. And then before, within a year or so, this patient would need cataract surgery. So sclerobuccal is what we do from the outside. It's a very nice procedure, but it's becoming less and less popular because it's tedious. And so more and more 40-year-old vitreoretinal surgeons are very uncomfortable doing them, because the more uncomfortable they are, the less they're going to do it. And then they never get good at it, right? And so it is a procedure that two things that I became an expert during my 35-year career. First, one was sclerobuccal. in the beginning, in my 30s, right out of fellowship, retinal detachments tend to come in the most inconvenient time. Usually it's like Friday, 5 p.m. or any weekday late, and you have full day clinic next day. And then the OR is already down to a couple rooms open, and you have to beg, and you're lucky to get the patient in at 11 p.m. So therefore, my senior colleagues had no qualms about turfing those cases to me, even when they were on call. So I then end up doing a lot of scleral buckles in the beginning of my career. And so, as we all know, practice makes better. And so I became really good at it. And so now when we have a vitrectomy vitreoretinal course, I often am the invited speaker to talk about scleral buckle or the pearls of scleral buckle, because I have collected just so many great cases. And so I can share that with the trainees, what to do and what not to do when one is performing a scleral buckle. And the nice thing about, so this is a disease that nobody else wanted it. And I took on, and I became pretty good at it. There was a woman that I did scleral buckle in her it was just shortly after my fellowship. And 30 years later, her parents were so grateful and donated $1 million in my honor. And this is the surgical training lab that we used the $1 million to build. Has nine Zeiss microscopes with the most beautiful video system and a teaching station. And we just run courses and courses throughout the year. And when we have resident applicants and fellow applicants, this is definitely a room that we tour them through, because it's sort of an envy of other programs, because it's just a beautiful facility where we do a lot of teaching. And here I'm working with first-year fellows how to do scleral buckle. Another expertise I acquired as a vitreoretinal surgeon, again, it was because my other colleagues didn't want to get near this patient. So late 80s and early 90s, as you know, HIV, at the time, there was no heart therapy. Patients will come down with HIV, and next thing they have AIDS. Their CD4 count goes under 200. And this is when they develop all sorts of infections. And the one that became quite a problem in the late 80s is CMV retinitis, because we really didn't have a drug for it. And so somehow many of my colleagues just would avoid patients with HIV, as if they touch these patients, they're going to catch HIV. But anyway, so I start seeing patients with question of any infectious retinitis. And then before you know it, when MGH HIV service learned that I wasn't hiding from them, I was willing to see their patients wherever they needed me to see them. Then I start seeing all their patients. So the ID service starts sending me all their patients. And so what happens when you see a lot of patients with infectious retinitis, you become good at it. And so in my first 15 years, I saw so many HIV patients with infectious retinitis, not just CMV retinitis. Then I just learned how each infection, how they present, which infection is associated with a lot of inflammation, which barely has inflammation. So I then was able to have a very clear list of details that I can teach residents and fellows and medical students how to narrow down the differential. So here, this is a classic CMV retinitis. The picture is beautiful. It's because patients come down with CNV retinitis when they are very immunosuppressed, so they cannot mount inflammatory reaction. So that's when you see a beautiful, clear picture because there are hardly any cells. The patient is unable to mount, even though with such a large patch of CNV retinitis, there are just hardly any inflammatory cells. They can also develop this what we call frosted angiitis. This is also caused by CNV. Now, this is a herpetic infectious retinitis that can happen to any one of us. You do not have to be immunosuppressed. It can be a 16-year-old or a 60-year-old, and is called acute retinal necrosis. Is one of them. I don't know of another infection that's scarier, because this patient probably started about 2 weeks ago. It takes few weeks to have the whole retina destroyed. And so it's a very, very scary retinal infection, and does not spare healthy people. This is toxo, somehow congenital in utero toxo-love macula. So often patients, if they get toxo in the second trimester, they often will have this macular lesion. And then what happens later on when they're born, they can have throughout their life reactivation. So this is secondary toxoplasmosis, which is pretty easy to make the diagnosis because the resident will see there's a scar and then there's this fluffy retinitis. So usually this is an easy diagnosis to make, that this is a secondary toxoplasmic retinitis. Primary toxo now is much harder, and you need to have some experience because this could be another diagnosis. So this is what we call headlight in the fog. You're looking, you see this bright light bulb, and then it's very hazy vitreous. So a solitary lesion. So this is how primary toxoplasmic retinitis presents, and takes a little bit of experience to dare to call this primary toxo. This patient, 35-year-old healthy man, comes in with very poor vision, 125. You can barely recognize where's the optic nerve. You know it's there because you can follow the vessels, the arcades, the supratemporal, infratemporal arcade. So the whole optic nerve is just destroyed by this infection. And again, based on one's experience and after good history, you kind of can narrow down the differential. I went along and I felt this was primary toxo and treated the patient with Bactrim, sulfa, and you can see how the patient gradually improved. I give you the dates so that you can get a sense how long it's taken this patient to get to this stage. Vision continues to improve, and then I would have never expected that this patient would have got 20/20. He has definitely some atrophy, pale, dyspallor, but visual acuity is 20/20. So this was primary toxo. This is a 23-year-old guy with pain and redness for 2 days, and then black spots for a couple of weeks. The patient has this lesion probably developing for several weeks, maybe even a month. And then what happens that when the inflammation from the back pours into the front part of the eye, once cells get into the anterior chamber, that's when pain, redness, photosensitivity occurs. So just because the patient has pain and redness for 2 days, I know this by looking at the fundus, this is not a 2-day disease. This is something that's been brewing for many weeks. And this presentation, and then you can also see little like pearls in the vitreous. It's almost like a pearl necklace. So these are usually suspicious for fungus when you see this kind of vitreous puffs. And then you take a little more history, and sometimes you have to repeat and repeat and repeat, because often patients with this particular history will kind of lie to you, will not be very honest. So this patient turned out is a heroin user, And of course, we always test for HIV when they're IV drug users. So this turned out to be Candida endogenous endophthalmitis, which has become very common. We see this all the time in our emergency room because there's such an endemic of IV drug users. This patient, gradual loss of vision in the right eye. And you can see underneath the retina, there's a plaque. There's something not right, right? Because you see normal fundus. There's something not quite right. There's something whitish, it's deep to the retina, and the optic nerve is blurred. And I suspect there was also something going on the left eye, but I don't expect you guys to appreciate that. But definitely the right eye, there's definitely something going on throughout the posterior pole and extending outward. So this was in 2015 when we were actually American Academy of Ophthalmology even put out a notice of a surge outbreaks of syphilis. And so syphilitic retinitis is almost our residents hardly see CNV retinitis. We see no resident will graduate without seeing at least one syphilitic placoid chororetinitis. And you can see syphilis has been gradually going up. And so it doesn't take too many spirochetes for a person to catch syphilis. And because of now there are more and more syphilis in heterosexual patients and women. So what happens that now throughout the world, we have a surge in congenital syphilis, which is very, very sad. All right, so when one is faced with all these really scary cases, there's this long-winded differential, but the eye is very intolerant of inflammation infection. You do not have the luxury of spending 7-8 days to work up the patient to figure out what the patient has. So I always call this a medical student differential. But we as a retina surgeon, when we are faced with cases like this, we have to narrow down to like 3 or 2, most likely, and start treating this patient because, as I said, the eye cannot tolerate massive inflammation. It just will go into a shutdown. And even eventually you control the infection, the eye goes into this little shrivel like a raisin. It's just the inflammation is very destructive to the eye. I find that more and more my young colleagues, because they have access to so many imagings and tests, including PCR, most of them become a little bit kind of complacent, lazy, and just do a tab and send off lab tests and wait for that to confirm before they treat. And I often find that that is just not acceptable because unless you own a PCR lab, you don't get the results. The few times I use the PCR lab, it's like 8 days to get the result back. You had to FedEx the specimen to that lab, and then they don't test every day all the pathogens. Often they just to be more economical, they may do Monday, Wednesday, Friday certain viruses, and then Tuesday, Thursday. So if you miss that, so usually it takes about 8 to 9 days to get results back. So in this 30 years of managing so many patients with infectious retinitis, again, mostly because nobody else wanted to touch these patients. And also they're very time consuming. When you admit these patients, remember you have to write daily notes, right? So there are many vitreoretinal surgeons who are very busy, and particularly if they're not in a hospital setting, they are in private practice, they will have to come to the hospital and write a note on this patient. So lots of them would just not want to manage patients with this kind of tedious conditions. And what I have learned is there's nothing more important in working up these patients than taking a good history. You all, as a medical student, have been taught from day one how the history is so important. So listen to the patients, and then also obviously you have to know what questions to ask. And so I usually find that after asking good questions, and then you examine, and after your examination, then go back and ask some more questions based on what you have found. And so I'm going to share a case with you where a good history really matters. This is a 26-year-old healthy young woman. Again, went to see an outside private practice ophthalmologist because she noticed while she was watching TV that she had sudden loss of vision in the right eye. Obviously, we know this is another one of those pseudo sudden loss of vision. She probably rubbed her other eye and noticed that she couldn't see from the right eye. She saw actually a very good retina doctor who I know his work, I respect his work, and he thought that this could be toxo or that herpetic acute retinal necrosis that I told you from herpes. So he put her on sulfadiazine, pyrimethamine, and leucovorin in case was toxoplasmic retinitis, and also started her on Valtrex in case it was acute retinal necrosis, and gave her, because he saw how much inflammation she had, he also gave her 30 milligrams of prednisone. And he watched her every day. He was very good about following her. And then he noticed that by day 3 that she maybe looked like a tiny bit better. But again, so you had to be careful when you put people on prednisone. They can look a little bit better because you reduce the inflammation. But then he called me and discussed this case with me. And I asked him about the patient's history, and he told me the patient had no history of IV drug use. Therefore, endogenous endophthalmitis was not on the differential. So when he described to me on the phone, it was just hard for me to figure out exactly how to advise him what to do. So I offered to see the patient. And so this is 5 days on the regimen that the outside doctor had placed. So I looked at her. The left eye was pretty normal. And I did not see any of that herpetic retinitis lesion. I felt like ARN, acute retinal necrosis, was out of question. Yes, toxo is possible. Had very stringy vitreous debris. I really felt like endogenous endophthalmitis made more sense, but I know he had already told me he asked her that question and she denied it. Meanwhile, she tells me that she had not put out any urine. She had been vomiting for days. And so we quickly did some lab tests and found that she was in renal failure. So because I felt like this was not like a acute presentation, I sent her to Mass General for her to be worked up, to be managed for her renal failure. So I really did not think she had a hepatic retinitis. So this were all my differential. Because she only had in one eye, there was nothing that left. She was too young to have intraocular lymphoma. I narrowed down to the top two. And I felt like was more fungal endogenous endophthalmitis. And this was when, she's always with her mother. And so I politely asked her mother to leave the room and ask her the question one more time. And then meanwhile, I want to show you what the wonderful medical student at Mass General who was assigned to her went through all her urine and found these crystals. And so these are what we call shocker wheat. And so her renal failure was caused by sulfidizing crystals. And so every medication that we put the patient on, of course, has potential side effects. And so she had urine crystals. And endogenous endophthalmitis, in the old days, when I used to see patients with endogenous endophthalmitis, they usually were sickly patients, immunosuppressed, chronic diseases, chronic steroid use, indwelling catheters, some invasive studies recent surgery. But now more and more patients are coming in with endogenous endophthalmitis from IV drug use. So in her case, if you really suspect endogenous endophthalmitis, you just have to figure out how to pull that from them. I always say that sort of like talking to my teenage children, who now they're all past the teenage days, but you're just going to have to figure out how to go back and ask that same question in a different way. And so she then said that she had done IV drug just that one time. That's all I needed to hear. And so then we took her to the OR, and she had vitrectomy, and she was given IV amphotericin. You can see this is what grew out of her vitreous specimen. It was aspergillus, and she's done very well. And we got rewarded by a nice case presentation at the CPCMS General. So again, so what I'm saying is there's two expertise that I picked up in the beginning of my career, were two things that nobody else wanted. So you never know. Don't feel sorry for yourself when you are doing something that other people dumped on you, and something good may come out of it. So as ophthalmologists, you have to be very you have to like details. You have to like little things and doing things with your hands, and you have to be honest with yourself throughout. As a medical student, when you do your surgical rotations, do the attendings comment about your skills? Are they pleased with your skills? Do they, you have to, if you struggling with general surgery, I feel like then you have to be honest with yourself, because then maybe you should not consider ophthalmology, because ophthalmology is very detailed. Is a microsurgical field that if you are clumsy and you don't have good hand-eye coordination, there are so many specialties in medicine. You don't want to spend 3 years of residency and struggle through because it is a surgical specialty unless you become a neuro-ophthalmologist. But as focused as you have to be, you also never want to lose sight of the big picture. I am open now for questions.
Dr. Young, thank you so much for that talk. What a wonderful variety of cases, and really a fantastic way to show off the field. With the next maybe 10, 15 minutes or so, we'll move on to our Q&A portion of the session tonight. Just a reminder for everybody in the call, the way we like to do this is with the raise hand function on Zoom. So if you have a question you'd like to ask Dr. Young, please click that little reactions tab, and then you can click raise hand. You'll pop up here. I will call out names in the order that I see them, and then we'll go through the Q&A like that.
So I saw a question on what is retinal neovascularization. So wherever there's retina ischemia, then I always tell the patients, the brain gets full, it senses ischemia. And then what does it do? It's going to make new vessels to perfuse that area. Unfortunately, neovascular vessels are very bad. They're very fragile. They burst, they bleed, even if with a little cough, little weightlifting. And so when sickle cell causes peripheral retinal ischemia, retinopathy of prematurity has poorly perfused circulation in the peripheral retina. So they develop neovascularization, and that is very bad for the eye.
One question to maybe just kick us off, Dr. Young. If you could comment at all on kind of what your maybe week in the life looks like, and what your division is between research, between teaching, between patient care, and then maybe kind of how you arrived at that balance and what was important for you in getting there.
Yeah, so in the beginning, I was a assistant. Well, at Harvard, we started off as instructors. One of the few places you don't start off as assistant professor. So I knew I was in an academic track, and obviously I knew I needed to publish. I had to not just see patients, I needed to publish. So I had various research projects going on right from the beginning, and helped that I had my PhD with John Dowling. So I was able to actually, throughout my residency, fellowship, and beginning of my career, I was still able to use his lab. So I didn't have to set up a lab. I was able to, in the evenings and weekends and wherever I had time, I could just go to his lab and do my research. He was just the most generous person. He let me use his lab, even though I wasn't publishing with him. So in the beginning, I would say I probably at least 40% of my time was research. Particularly in the beginning, if you do spend less than that, very hard to kick off your research project. And also there's a lot of time that required to write grants. And so in the beginning, you really have to allow yourself at least 40-50%. And obviously, hopefully, the chairman supports your work, and maybe in the beginning will give you some startup money, so that you're not so pressured to come up with, because without money you cannot do research. And so hopefully you bargain for some kind of support the first 3 years. So I was not a high volume clinician in the beginning. I now am a very high volume clinician, but in the beginning, my clinics were light. I had only like 2 clinics, and then a lot of time in the lab.
Thank you so much. Rochelle, nice to see you again. You want to go ahead and kick us off with your question?
Yes, thank you, Nick, and thank you so much, Dr. Young. I was wondering, in terms of getting more research experience, like right now, I'm a second-year medical student, and I'm pretty sure I want to specialize in ophthalmology. Would you recommend doing like additional research during like a research year? And if so, when would that best time be? Like after second year, after third year, before auditions, or after graduating medical school, just applying like next year for residency? What do you think is best, or what have you seen been successful?
So I've seen people, resident applicants here, Mass & Ear, have taken time off in really, I don't think it matters when, but unfortunately, ophthalmology still, even though I hear dermatologist number one, the most popular residency to go into, is still very, very, very competitive. And so to have some kind of research project without taking some time off, I think is almost impossible. So I see more the applicants having taken a year off. It could be, in the end of your medical school, or in between third and fourth. So probably it might be a good idea before sometime in after your third year, to do that gap year. Because then you still have some clinical work. What happens is that when you apply for internship, some of the internship programs, like I did very well with my residency application, everybody wanted to give me an interview, but the internship programs were a little bit suspicious of me because I had spent 3 years in the lab. And so I was not I did not do that well applying for internship, just because they felt like, is she going to be a little more than rusty when she starts on July 1st? So our Mass on Year program now, and I think many other programs now have a locked-in internship. So I guess here you wouldn't have to worry. But then if there are some other programs that require that you apply for internship on your own, they may not like that you took a whole year off after your 4th year medical school, and then maybe you've forgotten some of the basic stuff.
That makes sense. Thank you so much.
Tassim, do you want to go ahead and ask your question?
Yeah, sure. Thank you so much for your time, Dr. Young. This was a really enlightening talk. And thank you all so much for setting this up. So a question I had was, when seeing a lot of these cases, and you actually allude to this as well in one of the later cases, a lot of the cases you talk about have very broad, very interdisciplinary differentials. Can you walk us through a little bit of the thought process you have when you see one of these cases with a broad differential, and when you think to yourself, especially because you also mentioned the time crunch with retinitis?
Yeah.
Can you speak to like the thought process when where you're like, okay, I need to manage this myself and as quickly as possible, versus like, when do I need to send this out for labs, or when do I call, say, an IM or ID consult?
Yeah. So when it comes to infectious retinitis, then so what happened is I have many colleagues here who are high volume surgeons. So they love macular pucker, which is a membrane that grows on the macula, and then you just tease it off. It's a quick 40-minute procedure, or a macular hole. So there are some vitreoretinal surgeons, they are high volume surgeons, and that's the kind of stuff that they like to do. And if they have done that for the last 10 years and they have not seen infectious retinitis too many times, they're not going to manage those patients well. They because they're going to want to do every little test. And like I said, unless you own a PCR lab, you are not going to get results back. So often, I think you owe it to the patient to then call. There's me, and then there's Lucia Sobran. There are a few of us here, and we see this kind of cases day in, day out. So when we see an eye filled with pus, we don't freak out. We don't feel like, oh, I got to tap and send out for culture, and then not know what to do until that result is back. So those are really is years of experience where so I have like a 2-hour talk on infectious retinitis, and I really try to condense it. Really went fast, but for example, a good history. I will make sure I understand whether this has this sort of progress in 2-3 days, or this has been weeks or months. Like ocular lymphoma in an 80-year-old, probably months of building up floaters in that eye, decreasing gradual loss of vision. Toxo, probably weeks. It doesn't happen. Even if the patient comes in, like I said, like stating that everything was fine until the last 2 days. Now I have redness and pain and photosensitivity in the last 2 days. Yes, that's a good history to start off with. But once I examine the eye and I see what I see, I have to trust my exam. And I know this patient has become symptomatic because the cells pour into the front part of the eye, and now it's giving him redness, pain, and photosensitivity. But based on my exam, I know this condition has been brewing for many weeks. And that will already change my differential. I'm already not going to be thinking about bacterial endogenous endophthalmitis. I'm going to be thinking about toxo. So really, the temple, the vitreous presentation, multiple lesion like in acute retinal necrosis, you see a myriad of retinal infiltrates versus primary toxo endogenous endophthalmitis. You're going to see one lesion because often, like endogenous, a fungus came into deep to the retina, into choroid, and slowly work itself up, proliferating into the subretinal space and then into the vitreous. So you see the is solitary lesion. So it's really history, how the vitreous looks, and retinal lesions, solitary versus a myriad of lesions. All that helped me to narrow down to 2 most likely diagnosis so I can work with. Otherwise, if you have this 10 differential, you just become paralyzed. You don't dare to do anything until the results come back. And then by then the eye can be gone.
Thank you so much.
All right. I think to be mindful of everyone's time, we'll just have one more question. Vincent, if you want to go ahead and ask yours.
Hi, Dr. Young. Thank you for being here today. I'm in a research year glaucoma lab with Dr. Weinreb and Dr. Mokimi at UCSD.
Great.
So, yeah, so there's a lot of OCT and OCTA in this. So my question is, do you see the future of retina still using OCT and OCTA imaging, or are there more better imaging on the horizon for retina research?
All right. So I'm still learning OCT. So you probably know more OCTA than I do. Okay. So I love OCT. And the OCTA in the last several years, my younger colleagues are doing lots of research with OCTA. And I know like one colleague at Tufts, her wide field OCTA is just beautiful. It's almost like there's no need to do a fluorescein angiogram. They're just beautiful, but still right now, most people don't have that wide field OCTA. So OCTA is optical coherence tomography angiography. And so without putting like the angioma that I show you require fluorescein injected into the arm vein and then lots of pictures taken. What Vincent, right? Vincent is talking about is that it's almost like an ultrasound where and then you don't need any dye and you can look at the vessels at different layers of the retina. So that definitely whether we'll replace it. So we do fluorescein angiography very rarely these days. The OCT alone has given us so much, it's such a useful diagnostic tool. I have another lecture that I give, which is the diagnostic tools and their applications to retinal diseases. So back in my days, 1988, when I was coming out of residency, beginning my fellowship, we had Goldman visual field, we had fluorescein angiography, and your standard ultrasound and electroretinogram. Since then, we have multifocal ERG, we have OCT, we have genetic testing. What else? We have HLA typing. We have so many more tests now that we can diagnose diseases with so much more ease. And I have no doubt in the next 20 years, you will be exposed to, and you may even be the one to discover another tool for retinal diseases. That's another fascinating field in retina, is that I feel like it's such a technical specialty and has invited lots and lots of discoveries.
Thank you very much.
All right, guys. Thank you so much for a really awesome group of questions. And thanks, Dr. Young, for wonderful answers. We're going to go ahead and wrap up the Q&A portion now, and I'll just pass it back to Nathan for some closing reminders.
Yeah, I just want to say thank you, Dr. Young, for your really informative and great presentation. And just for closing, thank you all for coming and for being part of this curriculum and for learning alongside us. It really means a lot that we're able to gather in this way and learn so much about the subspecialties of ophthalmology. This session is recorded, and so we will be uploading it to the website. It has taken us a bit longer, so it might be a few weeks. Hopefully we'll have the recording from our last month session as well up. And we also stay tuned for an email announcement about our December speaker. That event will be happening on Tuesday, December 12th from 6:30 to 7:30 p.m. Eastern, and it will be on neuro-ophthalmology with Dr. Amanda Henderson, who is the chief of Neuro-Ophthalmology and Associate Residency Program Director at the Wilmer Eye Institute at Johns Hopkins. So stay tuned to that. Have a wonderful night, everyone, and thank you again for coming.
Thank you for having me. Thank you. Good luck to all.